Hello and welcome. Wherever you are in the world, we're delighted to have you with us. And today we're going to look at one aspect of central precocious puberty. This forms part of a three-part series, and my name is Martin Savage. I'm delighted to have Sasha Howard with me, joining this project. And essentially, we're going to look at different, this is my disclosure, different components of true precocious puberty. And here you see them outlined. We've done the first one in October. Today is today, and then the next one is in December. And we will look specifically today at the genetic causes of central precocious puberty and basically look at their current metabolic complications and any other associated clinical features. So essentially, this process of education is a global medical education provider. It's dedicated to designing, delivering, and evaluating medical education programs worldwide, offering support to healthcare professionals in their continuing professional development. And the meeting is organized by Medea, based in Italy, with there are certain partnerships. And for example, one partnership is with the International Korean Committee, and we're delighted to have you here participating in the webinar. And the independent educational program is made possible thanks to an unrestricted educational sponsorship provided by Ipsen Pharma. Here is the program, which I will again repeat in a minute. And essentially, learning objectives: be confident in the diagnosis of CPP, be aware of the main genetic causes, and consider the different metabolic consequences of different genetic mutations. This is your Q&A reminder. So basically, we would be delighted if you would write down questions either on your chat box or below in the Q&A box, and we will look at these questions afterwards. Accreditation is very important. The meeting is accredited. In order to receive your certificate, you need to complete the accreditation form, and these are the certificates you will receive. So it's an enormous pleasure for me to introduce our speaker, Professor Jesus Argente from Madrid. Professor Argente is well known in the pediatric endocrinology community, not only in Europe, but also worldwide, as an outstanding clinical investigator. His group has investigated different components of true precocious puberty and looked specifically at genetics as a potential cause. And because clearly there are many genetic variants, this is going to be really the subject of his presentation. So, genetic causes of central precocious puberty, metabolic alterations associated with genetic diagnosis of CPP. So Jesus, welcome. and it's over to you now. Thank you.
Thank you very much, dear Professor Savitz, dear Martin. It is a great pleasure to be here with you today and sharing our knowledge regarding the genetic causes of central precocious puberty, as you said. And I don't know if I need to pass my slides. Yeah. Here, I have nothing to disclose regarding this topic. So the learning objectives today, after these presentations, should be, number one, to be confident in the differential diagnosis of central precocious puberty. Number two, be aware of the main genetic causes of CPP. And three, consider the different metabolic consequences of different genetic mutations for CPP. It is very important for all of you to know that there is a new window in research in CPP during the last 10 years, and we are learning a lot from genetics and the relationship with CPP in our patients. However, more research is still necessary to better understand our patients. So here is the outline of my presentation today. I will first mention the sequence of pubertal events in normal boys and girls. Central precocious puberty, I would like to introduce the concept, etiology, and clinical types. And I will mention mainly the molecular basis of CPP today, as well as my conclusions and the take-home messages for you. As everybody knows, this here is the sequence of pubertal events in boys and girls. And you know that the concept of central precocious puberty or precocious puberty in general is still arbitrary. So in fact, we consider that girls starting puberty before 8 years of chronological age and boys before 9 years of chronological age is the concept of precocious puberty. So as everybody can understand, this old concept is still present and is empirical and is arbitrary, but this is the concept we have today. So central precocious puberty is caused by premature activation of the pulsatile production of hormones from the hypothalamus secretion of gonadotropin-releasing hormone GnRH, which can be caused by either congenital or acquired disorders with or without central nervous system abnormalities. We know that several factors have a role in pubertal development, including not only metabolism, but also environment and genetics. So here I'm showing you the presence of sexual dimorphism in the etiology of precocious puberty. In fact, most of the females exhibit an idiopathic cause of CPP, while most of the males exhibit an organic cause of CPP. And it means that MRI, especially in boys younger than 6 years of age, is absolutely necessary in order to make a proper diagnosis indicating whether either an intracranial tumor or amartoma mainly can be present. However, this is in fact very rare in girls. So when you look at the causes of central precocious puberty, of course, we have patients with CNS lesions, either congenital or acquired. But today we are going to talk about patients with non-documented CNS lesions, and mainly due to genetic causes, including KIS1 gain of function mutations, KIS1 receptor gain of function mutations, MKRN3 loss of function mutations, DLK1 loss of function mutations, and another genes that I will mention at the end of my talk. So we have recently published in Lancet Diabetes Endocrinology an interesting review, in my opinion, about normal and pathological puberty that could be of interest for the audience to read. So the diagnosis of central precocious puberty requires, number one, the presence of early onset and progression of sexual characteristics. Second, a linear acceleration of growth. And finally, an advancement in bone maturation. So of the patients referred for probably precocious puberty, less than 10% are diagnosed as having CPP. So CPP is a rare disease with a female predominance. Clinical, hormonal, and radiological data are, of course, essential to make a proper diagnosis. And once the diagnosis has been made, the type of precocious puberty and its etiology must be investigated in order to know whether we are in front of a patient with CPP or a peripheral precocious puberty, and what is the cause of one of them. So here in this cartoon, I'm showing you the monogenic causes of central precocious puberty that we know today, and I mentioned in my previous slide. So number one is including patients with gain of function mutations in KIS1. Those mutations are very rare. Second, mutations in KIS1 receptor, also very rare. And loss of function mutations in MKRN3 today is the commonest cause of monogenic CPP. And finally, loss of function mutations in DLK1. The story of our knowledge started in 2008 when telesanco workers published in the New England Journal of Medicine a GPR54 activating mutation in a patient with central precocious puberty. So as you know, a G protein coupled receptor, GPR54, and its ligand, kisspeptin, stimulate the secretion of GnRH. This patient exhibit a mutation in arginine at codon 388 to proline associated with central precocious puberty. But this patient was an adopted girl, so we do not have any information about the family. Later on, in 2010, Silveira and co-worker published this interesting paper in GCM showing 3 patients, one male, 1.6 years old, with a mutation in heterozygosis, as shown here, and 2 girls with being 5 and 6 years old, respectively, with another mutation in homozygosis in the KIS1 gene. Interestingly, this little boy exhibit high levels of testosterone and LH, and his mother and grandmother had the same mutation, but without central precocious puberty. So sex-dependent phenotype and our incomplete penetrance is the question to try to understand this situation. In 2009, there is here one important patient that I like to mention, published in European Journal of Human Genetics. When this patient that I'm showing you here was diagnosed with Prader-Willi syndrome. However, this patient exhibit idiopathic precocious puberty. So the authors were really interested in investigating this patient because they couldn't understand why idiopathic precocious puberty was associated with Prader-Willi syndrome. So when they analyzed the physical map of the long arm of the chromosome 15 in the area 11-13, they clearly saw a paternal deletion of 3 important genes, MKRN3, MAGEL2, and NDN. And the authors conclude that this deletion does not result in Prader-Willi syndrome. And the paper stayed there, I'm talking about 2009, until 2013, when Abreu and co-workers published this very relevant and important a paper in the New England Journal of Medicine in 2013, analyzing mutations in the macaroon ring finger protein 3, MKRN3. MKRN3 is an intraless gene in a region containing an imprinted gene cluster in the long arm of chromosome 15, and it undergoes maternal imprinting. Hence, only the paternal allele is expressed, while the maternal allele is silenced through methylation of CpG islands. The authors describe inactivating mutations in this gene in 15 patients from 5 different and related families, including not only girls, but also boys. And this manuscript really opened a new line of research till today. So in a collaboration with Dr. Latronico at the University of Sao Paulo in Brazil, we organized national database of central precocious puberty in Spain, and we decided to analyze a huge, important number of patients with CPP, specifically 716 patients with familiar or idiopathic CPP screened for MKRN3 variants. We found 71 patients, 45 girls, and 26 boys, with 18 different loss of function MKRN3 mutations. And here, we published in GCM in 2021 the presence of the kind of mutations we already knew at this moment related to MKRN3. And as you can see in red, we have frame-shift mutations, in blue missense mutations, and in yellow nonsense stop gain. This is in 2021, but in a beautiful review that we did in Endocrine Reviews in 2023, the number of mutations dramatically increased in patients with CPP analyzed internationally, as you can see in this slide. So we have described so far detailed phenotypic characteristics of the largest multi-ethnic cohort of patients with CPP harboring loss of function MKRN3 variants. All pathogenic variants were evaluated according to the ACMG criteria. In order to establish genotype-phenotype correlations, pathogenic variants were classified as severe, including frame-shift, stop gain promoter region, or missense mutations. So 37 were newly reported and 34 patients had been previously described. Another important gene that is necessary for all of you to understand not only our knowledge, but also the necessity to perform more research is DLK1. The delta-like 1 homologue, DLK1, is also a maternally imprinted gene in the long arm of chromosome 14. DLK1 is a non-canonical ligand of Notch signaling that controls many developmental processes. In fact, we knew that DLK1 knockout mouse is associated with obesity, growth retardation, and skeletal malformations. Historically, DLK1 mutations have been associated with a neurodevelopmental syndrome called Temple syndrome. Today, we know that some loss of function mutations have been described in children with CPP, as I will show you in the next slides. So in humans, metabolic abnormalities such as overweight, obesity, type 2 diabetes mellitus, and hyperlipidemia are more prevalent in women with DLK1 mutations. So I would like to highlight the fact that DLK1 represents, in fact, a new link between reproduction and metabolism. And the metabolic profile should be considered both in mid-childhood, adolescence, and adulthood. Here I'm showing you some DLK1 variants that we described in our Brazilian Spanish study. And as you can see, we found an important deletion in the promoter of the gene. And we have different mutations in exon 4 and exon 5 of this gene, showing you in the lower part of the slide the proteins derived from these mutations. So in this manuscript that we published in GCM in 2020, we had the opportunity to measure DLK1 protein levels in plasma in patients with DLK1 mutations. And as you can see, we didn't find any significant difference between the control group and obese patients. However, patients with DLK1 deficiency exhibit very low or even undetectable DLK1 levels, which is of interest because it's quite easy and not very expensive to measure the protein DLK1. And of course, if this protein is low or undetectable, then we could perform directly our genetic studies to this gene. Later on, we published another mutations, as shown here. And recently, Danielo and coworkers published this interesting paper in Hormone Research and Pediatrics, analyzing the role of DLK1 deficiency in central precocious puberty and association with metabolic dysregulation. I think it's important because they make a very nice review about all of our knowledge in 2024. So they published a patient of Bangladesh origin diagnosed with CPP, and they found to carry a de novo heterozygous stop gain mutation, as shown here in exon number 5, in DLK1, with an impaired metabolic profile. In fact, as you can see in the upper right part of the slide, the patient exhibit very high serum triglyceride levels, as well as very high serum insulin levels, and also including total cholesterol levels in the upper part of the normal range. They had the opportunity to measure the DLK1 protein in plasma, and they found low serum DLK1 levels. So this is in agreement with our previous data that I showed you before. So when you look at patients with familial central precocious puberty, you can analyze them either performing whole exome sequencing, WES, or performing targeted panel sequencing. We have the possibility to analyze many patients here that I will describe now. We published in GCM in 2023 regarding these enormous pedigrees shown in this slide. So we analyzed 586 children with central precocious puberty, and we had the opportunity to see 111 children from 86 different families with familiar CPP. So we could conclude analyzing the prevalence of familial CPP in these patients. And we can say that the prevalence of familiar CPP in our cohort was between 22 to 30%, being in girls with menarche below 10 years. So maternal and paternal transmitted CPP were 39% and 38% respectively. Most of the families, about 85% with maternal transmission of CPP, have at least 2 generations known to be affected. This is an important data to keep in mind. The predominance of affected females in the family pedigrees, about 90%, suggest sex-dependent penetrance, which is also an important data. Nevertheless, more research is necessary to identify the monogenic cause in cases with negative results to date. And this could be due to copy number variation, to single nucleotide variation in regulatory regions not covered by WES, to epigenetic defects, to mitochondrial DNA mutations and or oligogenic or polygenic inheritance. Therefore, for all of the younger people in the audience, it's very important for you to know that there is an important area of research to be developed in the years to come. And because CPP is a rare disease, it would be necessary to make efforts, multinational efforts, to have more patients to be analyzed properly and to make solid conclusions. More recently, in 2023, in collaboration with the Brazilian team and also with Professor Sasha Howard from UK, we discovered 7 patients, 2 from UK, 3 from Brazil, and 2 from Spain, with MBCP2 mutations associated to central precocious puberty. So this, the variants in this gene have been historically associated to patients with Rett syndrome. And then we wanted to analyze these different variants in patients with Rett syndrome in blue and in patients with non-Rett syndrome in red. And here is what we know today about MECP2 mutations associated to central precocious puberty in girls. So no information about boys and potentially abnormalities in this gene until this paper published by Cantone and co-workers recently, I guess it's still in press in GCM, but you have the DOI and the PMD in the bottom of the slide. They discover 2 hemizygous missense MEC2 variants in 2 unrelated boys with normal MRI. So patient number 1 exhibit a very early sporadic CPP with a speech delay and autism, while patient number 2 has a sporadic CPP with no neurodevelopmental disorders. Both patients inherited from mothers with normal puberty, and neither patient had features of Rett syndrome. So this is what we know today. Not much, but we are opening, again, a new window of research to try to understand the molecular basis of central precocious puberty. In conclusion, although multiple advances in our knowledge regarding the onset of puberty have been made, its mechanism still remain only partially understood. MKRN3 mutations represent the most common monogenic cause of CPP today. DLK1 mutations give new insight into the correlation between obesity and metabolic syndrome and pubertal development. Nevertheless, more investigation is necessary to better understand the mechanisms causing CPP and metabolic derangement in patients with DLK1 deficiency, as well as to clarify the inheritance model. In addition, more research on new genes involved in CPP is still necessary. So here I'm showing you the take-home messages that I consider are important today. We are developing with the Endocrine Society an international guidelines of CPP at this moment that will be published in a few months from now, where we discuss all of our knowledge and ignorance regarding CPP. I think that the most important areas include, first, the definition of precocious puberty that is still arbitrary, and we don't understand well why patients very young, 3, 4 years old, exhibit CPP, and sometimes patients being older than 6 years old, exhibiting CPP or early puberty that is not really the same symptomatology and the same characteristics that exhibit young patients. CPP is indeed a rare disease with female predominance and the most common form of precocious puberty. There is no doubt about it. In males, at younger age at onset increases the risk of CNS lesions, and this is why MRI, brain MRI, is necessary to be performed. Today, we clearly discuss whether brain MRI is necessary in females, especially in females older than 6 years old, and most of the clinicians agree that probably it's not necessary to perform a brain MRI in females older than 6 if they do not exhibit any neurological symptom. Diagnosis of CPP needs clinical information and the support of imaging and hormonal test. The GNRA test is the gold standard for CPP, although basal LH testing versus stimulating testing is under discussion at this moment, and many clinicians around the world just perform basal LH in order to define CPP. Genetic testing today plays an important emerging role in the diagnosis of CPP, including the genes I have mentioned. First, mCARN3, second DLK1, and last but not least, MECP2. GNRH analog is the treatment of choice in CPP with different types of formulations that we can use today, including monthly, every 3 months, or every 6 months. DLK1 variants, underlying CPP, and their metabolic associations needs further investigation. Finally, still more research in new genes involved in CPP is needed. So here is Las Meninas from Velázquez, and as you can see, the infanta here, she has a Bucaro, probably because she had precocious puberty. So observation and curiosity is always important because they lead to research improving our knowledge. And the conclusion is that we need to continue promoting teaching and research in central precocious puberty to unravel its molecular basis. I would like to thank my team in pediatric endocrinology at the University Hospital Niño Jesús in Madrid, linked to the University Autónoma of Madrid, for all of the work developed during many years. And of course, I would like to thank all of the colleagues that collaborate in the PURI study. This is a Spanish national study registered for patients with CPP, when today we have more than 500 patients included in our database, and we are following the evolution of these patients till they get the adult height. And finally, would like to thank very much Professor Ana Claudia Latronico from Sao Paulo University, Professor Ursula Kaiser from Harvard Medical School, Professor Leo Dunkel from Queen Mary in University of London, especially in the study of patients with delayed puberty and hypogonadism, and my friend and colleague, Professor Manuel Tenasempere from the University of Córdoba, with whom we collaborate in the basic studies of puberty. And of course, I would like to thank all of you for your attention. Thank you very much.
So, Jesus, thank you really for a remarkable presentation, extremely clear, good clinical guidelines along the way, and really something I think for every pediatric endocrinologist. Now, there are a number of chat questions, but let me start by saying that you said very little about GnRH.
Yep.
Now, basically, I've always considered that GnRH was the sort of the gateway to puberty development. Do each of these different variants result in GnRH deficiency in different ways? Is it possible to say that?
No, we cannot say that. The importance of performing GnRH testing is to investigate whether puberty is central or not.
Yeah.
If we have LH pulsatility, then we can conclude that there is central precocious puberty, and then we need to investigate whether this CPP could be genetic or not. But the GnRH testing is mainly to decide whether precocious puberty is of central or peripheral origin.
Yeah, but how do you arrive at GnRH or GnRH excess, basically, in a case of precocious puberty when the molecular background is so complex?
Well, I like to say always that the most important thing for us is the patient, is to explore the patient, to analyze the patient, and to see the patient. So if we are in front of a patient with a potential precocious puberty, then we need to make the diagnosis of to discuss whether this is central or is not. To do that, we can do either a GnRH test or to measure LH basal levels. If the GnRH test is indicating LH pulsatility or the LH basal levels are elevated, we can conclude that the central puberty is working. So the central puberty is the diagnosis. And if this happened in a boy less than 9 or a girl less than 8, as I said arbitrarily, we can conclude that there is a central precocious puberty. And then we need to analyze whether this patient has a familial central precocious puberty and a sporadic central precocious puberty, and then to discuss the potential genetic studies to see whether there is a genetic relationship with.
Okay, I get you. Right. So basically, there are questions about the use of GnRH in precocious puberty. How long would you plan to continue with GnRH therapy?
Yeah, this is a very important question. The point is, when did you start with? Because sometimes the patient is 4 years old, 5 years old, 6 years old, or sometimes the patient is a little bit older. And there are discussions when patients are older than 7 if GnRH analog treatment must be included or not. But if we decide to treat with GnRH analog, the discussion is when to stop it. And today, there is no international agreement. However, most of the people agree that in girls at 10 years of chronological age or 11 years of bone age, or in boys at 11 years of chronological age or 12 for bone age, the therapy should be stopped. We don't have rigorous scientific data to conclude, as I said right now, but this is the general terms that we perform in clinical practice today.
Right. Okay. Sasha, I see you there. Are there any questions you might have?
Yes, I think there was another question in the chat as well on that theme that was, would you stop the GnRH, go from full dose to stop it immediately, or would you do any kind of progressive decrease in the dose before you stopped?
This is another a very important question, another discussion. No international agreement, but most of the people prefer to stop completely because, as you know, before we use one injection every month. Therefore, we started with injections every 3 months, and some people use injections every 6 months right now. So when you stop the treatment, you stop the treatment definitely because you consider that you need to leave the patient free of therapy in order to finish their growth and also to develop normal puberty or puberty when the chronological and bone age is more appropriate for them.
Yeah, absolutely. And I always think that when we stop the treatment, there's always some period of time where the axis will then gradually recover. So it's going to be a gradual recovery of the patient's own natural GnRH, gonadotrophins, and estradiol or testosterone. So those won't shoot up very quickly. They will gradually recover. So in that way, it is a gradual increase in those endogenous hormones. Thank you.
I agree with you. Yeah.
There was some other questions. Which investigations would you do in terms of trying to assess if they have any metabolic derangement for a patient with CPP?
Well, in patients with CPP, as I mentioned in my talk, with potential metabolic problems, we analyze patients with DLK1 variants, and we include all of the, we measure total cholesterol levels, CA-HDL, CLL, CLDL, and of course, triglycerides and insulin levels. This is quite important. And as I said in one of my slides, we need to do these studies in mid-childhood, adolescence, and adulthood, especially in girls or women. This is exactly the reason why we try to investigate these problems that can include not only metabolism but also reproduction, because we are saying that in our patients that become an adult woman, they have some problems of reproduction and some problems with their menses, which must be regulated. So in conclusion, regarding your question, that is very important, and once again, we are investigating and we are trying to better understand this situation in these patients. I think it's quite important to perform these metabolic studies in patients with DLK1 variants.
Okay. And they then need screening lifelong for those kind of derangements. Is that, yeah. Okay.
Absolutely.
Okay. And do you also give them advice about their lifestyle to try and
of course
improve that where possible?
Extremely important too. So
there's another question in the chat about height-related considerations. So when you are thinking about stopping the GnRH analog, are you also thinking about their height and how to optimize that?
very good question. And the real answer is we don't know. But what are we doing in clinical practice? As I said, females with a bone age 11 years old, males with a bone age 12 years old, we should stop therapy because we know that we are not going to gain more in terms of height. And we need to develop the patients developing regular puberty. And in case of girls, analyzing the menarche and the menstruations right after that in order to see whether there is any problem or not. So this is what we do in clinical practice, and we stop therapy completely when we decide to do it.
Okay, thank you. There was another question about GnRH treatment about are there any negative possible outcomes or any health-related considerations?
Well, it is important to know for the general audience, especially the younger people, that GnRH analogs, we never perform a clinical trial with GnRH analogs in children. And generates analogs come from the treatment of endometriosis in women and prostate cancer in men. And we would prefer to have generates antagonists and not analogs. But we know at least 3 different antagonists, and none of them didn't work. So this is the reason why we use generates analogs. Regarding potential complications, we see local alterations in in the area of the injections. We see some females with delay menarche and menstrual abnormalities, and those are the main problems that we see with the use of generates analogs, as far as we know with our experience in children and adolescents.
But as you say, we haven't done a trial, so we don't know whether those abnormalities of reproduction they see later in life or are a consequence of the GnRH analog, or as you say, it's potentially a genetic underlying cause of both their central precocious puberty and then their ongoing lifelong issues. It's difficult to unpick that, isn't it?
Yeah, the answer is we don't know, and we have discussed all of the panelists analyzing this international guideline that I mentioned before with the Endocrine Society, and there is no evidence so far to answer this question. Although, of course, we need to pay attention in order to investigate and analyze potential problems in our patients treated with GnRH analogs.
Absolutely.
Okay, well, thank you very much for, again, a very lively discussion and excellent feedback. So now I'm trying to, there we go. So these are the certificates which you will receive once you have completed the accreditation form. Please fill in the forms. There's an on-demand webinar which will be available for 1 week. At 1 week after this, you will be able to follow. And this, I think, completes my series of investigations. Thank you very much indeed, Jesus, for really putting us in the picture and for your very enlightened discussion and clarification of points of contention, which we very much appreciate. Let me follow again.
So thank you very much, Martin. It has been a great pleasure to collaborate in this webinar, and I really appreciate your kind words as usual. And again, I thank you very much for the introduction and the comments you made about my talk. Thank you.
You're welcome. You're welcome. Absolutely welcome. And I hope we see you again and have opportunity to communicate again. And thank you to Sasha for really complementing the discussion and for your wise questions.
Thank you.
So I say goodbye from London. Keep well, and we hope to see you all again soon. And thank you for joining. Thank you.
You too. Keep well from Madrid. Bye-bye.
Bye.
Bye.